All right, we're gonna tighten. So we're gonna go through like all of the things. All right. So when we get patients set up, the first thing we want to look at the view so that the white line matches the 0 and the toes are pointed straight in the air. So that tells me that the toes are at 0. When I ask you to externally rotate, you're going to loosen this top dial. Externally rotate is going out this way, so you're going to watch the toes from external. Usually that first is to 40, so I'll say externally rotate to 40. And then you're going to turn this to lock it there. When we say bring it back to neutral, you're going to unlock it and externally rotate back. Get the 0 matched up with the white line and lock it again. If we say we want a couple clicks of traction, that means we want you to do it with this turn. So you're going to lock the traction here. So you're going to bring that to the lock and then turn this, which is going to pull the leg through this contraction.
That traction is like,
yes.
Instead of gross traction,
Yes,
it's a
so
fine
that's fine traction is through here. The big move of dislocating and reducing the hip. The first thing you need to do is make sure the hip is unlocked. So you're always going to unlock this. This is the first thing you check. You're going to unlock that and make sure that this leg moves. Then you're going to come back here. You're going to unlock the traction. And the move is going to be traction and external rotation. So you're going to go slow and gentle, traction, and externally rotate, and that hip's going to pop out. So usually I say traction, and then I'll tell you when to externally rotate. The goal with that is you want to pull hard but steady, because you don't want to go like this, and then we worry about breaking the femur. You also don't want to go hard, 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 and then twist. So everything you do, you think of slow and steady, and I'd rather we like lose it, right? Like we lose our tension, we have to try again, than you pulling so hard and snap it, because then we worry about the femur breaking. So then, when we've got the hip out, we're going to go maximal external rotation, which for most people is somewhere between like 90 and 120. We're going to get to where it is, where it's like tight, you're not forcing it, but it's making you work for it. Tighten this, that locks your traction externally. And then to drop the leg, you're going to take this, move it over, so that frees up this leg. You're going to go down to the floor, the leg will be attached, and bring it over. You're going to bring it as low as you can, bring it over, and then lock this. You can bring that over, it holds the leg. Here, the big thing you want to watch is this leg is here. So you just want to make sure that this operative leg isn't hitting this or this. And if so, we just have to bring it a little bit out. Then when we're reducing the hip, so the hip is dislocated, we want to put it back in, we're going to reverse it. So you're going to unlock this, bring it over, bring it up, and you want to match it to the other side so that these are even. Lock it even. And then we're going to do the opposite. So you're going to go traction, unlocking this, we're going to do traction, internally rotate, to 0. And that's where we'll kind of go the same thing. I'll say traction, 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 internally rotate. You want to do the same nice, slow, steady, and easy internal rotation to get it pop in. And you should feel a little pop. It's not going to be super aggressive, but you should feel that hip kind of clunk in. Then we lock it at 0. Sometimes when we're taking that x-ray, we want to get a better view of the lesser. So that's where I'll ask you like externally rotate to 5 or internally rotate to 10. So that you're going to do through here. So you unlock this and these numbers will give you on there. So sometimes we'll kind of leave it at 5 internal or external depending on the patient. I think that's everything.